Welcome to this Step 2 clinical knowledge review on sports medicine test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for sports medicine injuries and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the musculoskeletal and sports medicine sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize the classic question stems for sports medicine injuries that show up on your board exam. These include anterior cruciate ligament tears, meniscus injuries, rotator cuff pathology, shoulder dislocations, and overuse injuries like stress fractures and tendinopathies. Second, we will apply specific test-taking strategies to help you work through these questions efficiently. Third, we will master the next best step format that the boards love to use for sports medicine management. Make sure you have reviewed the musculoskeletal chapter in first aid and done questions in your question bank on these topics. Let us start with the most important first step in any sports medicine question. Determine whether you are dealing with an acute injury or a chronic overuse injury. This distinction drives everything else. For acute injuries, look for a sudden mechanism during activity, like a football player who plants and twists and hears a pop in the knee. Immediate swelling, which we call a hemarthrosis, points to an anterior cruciate ligament tear. If the vignette describes locking or catching with medial joint line tenderness, think meniscus. For overuse injuries, the stem will describe gradual onset over days to weeks, pain that worsens with activity and improves with rest. A runner with focal tibial tenderness likely has a stress fracture. A young athlete with anterior knee pain that is worse going downstairs suggests patellofemoral pain syndrome. Getting this acute versus chronic split right is your first move on every sports medicine question. Strategy 2 is all about matching the mechanism of injury to the diagnosis. For the knee, remember that a valgus force, meaning a blow to the outside of the knee, damages the medial collateral ligament. If the question describes a football player getting tackled from the side, that is your medial collateral ligament injury. A twisting or pivoting mechanism with a pop and rapid swelling is the classic anterior cruciate ligament tear. Meniscus tears present with mechanical symptoms like locking and catching plus joint line tenderness. For the shoulder, the classic anterior dislocation happens during forced abduction and external rotation. Think of a quarterback getting hit while throwing. The patient will have a squared-off shoulder and positive apprehension test. Rotator cuff injuries come in two flavors on the boards: acute tears from a fall on an outstretched hand in an older patient, and chronic impingement from repetitive overhead activity. The drop arm test and weakness with external rotation are your go-to exam findings for the rotator cuff. Now let us go through the high-yield stem patterns. For an anterior cruciate ligament tear, the classic stem gives you a young athlete who plants and twists, hears a pop, gets immediate swelling, and cannot continue playing. The Lachman test is the most sensitive physical exam finding the boards will test. For a meniscus tear, the key words are locking and catching. The patient has joint line tenderness and a positive McMurray test with a click during flexion and rotation. For shoulder dislocation, the mechanism is forced abduction and external rotation. The boards will describe a squared-off shoulder and may ask about axillary nerve injury, which presents as numbness over the lateral deltoid. Always remember to get radiographs before attempting reduction to rule out an associated fracture. These stem patterns repeat over and over in question banks and on the real exam. Let us work through this practice question together. Read the stem carefully. We have a 20-year-old female soccer player who twists her knee during a tackle. She hears a pop, gets rapid swelling within 2 hours, and cannot bear weight. On exam, the Lachman test is positive, and there is medial joint line tenderness. Take a moment to think about what diagnosis fits best before we walk through the answer on the next slide. Let us break this down using our 3-step approach. Step 1, spot the pattern. We have the classic triad for an anterior cruciate ligament tear, young athlete, twisting mechanism with a pop, and rapid swelling from a hemarthrosis. The positive Lachman test seals it. Step 2, apply the rule. On boards, a pop plus rapid knee effusion in a young athlete almost always equals anterior cruciate ligament tear. The Lachman test is the single most sensitive physical exam maneuver and is the one the boards test most often. Step 3. Eliminate wrong answers. A medial collateral ligament sprain would give you medial instability with valgus stress testing, not a positive Lachman. A lateral meniscus tear would cause lateral joint line tenderness, and meniscus tears cause more delayed effusion. A patellar tendon rupture would prevent active knee extension entirely, and you would feel a gap below the patella. The answer is B. Anterior cruciate ligament tear. Here is our second practice question. A 25-year-old man falls on his outstretched hand during basketball. He has severe shoulder pain, his arm is held in slight abduction, the shoulder has lost its normal rounded contour, and he has numbness over the lateral deltoid. That numbness over the deltoid is a critical clue because it tells you the axillary nerve may be involved. Think about what the most appropriate next step should be before we go to the answer walkthrough. This is a classic next best step question, and the boards love to test whether you will jump straight to reduction or get imaging first. The clinical picture is clearly an anterior shoulder dislocation. The squared-off shoulder, arm in abduction, and lateral deltoid numbness from axillary nerve stretch all fit perfectly. But the key here is the question asks for the next step in management, not the diagnosis. Before you reduce any dislocated joint, you must get radiographs first. This rules out fractures like a Hill-Sachs or Bankart lesion that could complicate reduction. Answer A, closed reduction immediately, is the most common wrong answer students pick because they want to fix the problem. But on the boards, imaging before reduction is the rule. Magnetic resonance imaging is useful later to evaluate the labrum and rotator cuff, but is not the acute next step. Electromyography is for evaluating chronic nerve injuries, not the acute setting. The answer is B, shoulder radiographs. Let us review the key management points the boards test. For anterior cruciate ligament tears, the acute management is rest, ice, compression, and elevation. Definitive treatment in young active patients is surgical reconstruction, typically done after swelling resolves. Medial collateral ligament sprains are almost always treated conservatively with a hinged knee brace and physical therapy. This is a classic board distinction. Meniscus tears that cause mechanical locking need surgery, either repair or partial removal, but small peripheral tears can heal on their own. For the shoulder, always get radiographs before reducing an anterior dislocation. After reduction, young patients have a very high recurrence rate, so they may need surgical stabilization. Rotator cuff tears in older patients are often managed with physical therapy first, unless they have significant weakness or a complete tear. Know these management algorithms well because the boards test the specific sequence of steps. Here is our third practice question. A 62-year-old woman falls on her outstretched hand and now has difficulty raising her arm overhead. On exam, she has a positive drop arm test, meaning her arm drops when you release it at 90 degrees of abduction. She also has weakness with external rotation. Think carefully about what diagnosis fits this presentation before we review the answer. Let us break this one down. The classic pattern here is an older patient who falls on an outstretched hand and then cannot raise the arm. The drop arm test is positive, meaning the arm drops when released at 90 degrees. Weakness with external rotation tells you the infraspinatus is involved. This is textbook rotator cuff tear. Now let us distinguish from the wrong answers. Adhesive capsulitis, also called frozen shoulder, causes restricted range of motion in all directions, both active and passive. It does not cause a drop arm sign. An anterior shoulder dislocation would give you a squared-off shoulder and the arm held in abduction, not weakness with raising the arm. A acromioclavicular joint separation causes a bump at the top of the shoulder and localized pain there, not weakness with arm elevation or external rotation. The answer is B, rotator cuff tear. Here is an important test-taking pearl about overuse injuries. The boards love to present a runner or military recruit with gradually worsening shin or foot pain and ask you about imaging. Remember that plain radiographs are often negative in the first 2 to 3 weeks of a stress fracture. When the clinical picture is classic, meaning focal bony tenderness in an athlete with repetitive loading, and the radiograph is negative, the next step is magnetic resonance imaging, not a bone scan. Magnetic resonance imaging is the most sensitive and specific study for stress fractures. Also, be ready for questions about the female athlete triad. When a female athlete has a stress fracture, the boards want you to screen for disordered eating and menstrual irregularity. This triad leads to decreased bone mineral density, which increases fracture risk. For other common overuse injuries, remember lateral epicondylitis is tennis elbow with pain on resisted wrist extension, and medial epicondylitis is pain with resisted wrist flexion. Iliotibial band syndrome causes lateral knee pain in runners that typically worsens going downhill. That wraps up our sports medicine test-taking strategy session. Let us recap the key takeaways. First, always start by identifying whether you are dealing with an acute injury or an overuse injury. Second, match the mechanism of injury to the diagnosis using the buzzwords we covered. Third, on next best step questions, remember that imaging usually comes before intervention, like getting radiographs before reducing a dislocated shoulder. For your continued studying, review the musculoskeletal and sports medicine chapters in first aid and work through sports medicine questions in your question bank. Focus on the physical exam findings, the imaging choices, and the management algorithms. If you found this video helpful, please like and subscribe for more board review content. And if you want personalized help, visit roadmap-to-residency.com, where our expert tutors and residency advisors can help you build a strategy for exam success. Good luck on your exam, and we will see you in the next video.